You know what kind of light it is? Has everybody seen capnography? They know how it's applied? Okay, has anybody not seen a capnography? You haven't seen it? Okay, that's all right. That's okay, you will. It is gradually becoming probably one of the most valuable vital signs, if you think about it. And it's gained popularity over the last, 20 years, more than that. But now it's being spread out into different arenas. Non-invasive is relatively new. It's only about 10 years old in the industry. But let's talk a little bit about, it measures carbon dioxide, correct? How does it do that? Well, it uses light. It uses infrared light. So if you've ever seen a bench, what we call a bench, it's an adapter that can go over there's an airway adapter, and then there's a cable that goes over that. Has anybody seen that type? Okay. There's another type that is just the airway adapter at the airway, and it has a capillary tube that goes to a sampling place. In each of those places, the bench and the sampling place, your capnometer, those measure infrared light. So at the adapter, everybody's seen what I'm talking about. They know that there's two windows, one on either side. Okay, on one side, the light shoots through the adapter. On the other side is a receiving end. Okay, as air goes through back and forth through this adapter, your CO2 levels go up and down and up and down, correct? So as the infrared light goes through the carbon dioxide, being a gas, it has a density, and it changes as you breathe in and out and in and out. So that's why you see the waveforms on capnometers. Can anybody tell me what the four phases of a capnography waveform are? Anybody know? Well, you can cheat. You can look right up there on the wall. In the upper left-hand corner, you'll see phase 1, phase 2, phase 3, and phase 4. It looks something like this. You've got a baseline, and it's going to go flat like this. Kind of like that. This is 1, this is 2, this is 3, this is 4. From 1 to 2, what is that? That's exhalation. Okay. Remember that an EtCO2 waveform is an expiratory waveform, not an inspiratory waveform. We are so used to seeing graphically ventilator waveforms. Well, ventilator waveforms are usually inspiratory waveforms. You see those on the face of a ventilator. They're up and down. They don't usually see an entitled CO2. So from here to here, what really is that? What is emptying? Where is that CO2 coming from? What part of the airway anatomically? Anybody know? Who said alveoli? That's here. How about dead space? Anatomical dead space. Trachea and large airways. That's this, from here to here. Then you start having alveolar emptying. And this is the critical part of a CO2 waveform, because this will change. Your emptying of your dead space is pretty much going to be static. It's not going to change all that much. This probably will, because from 2 to 3 is alveolar emptying. And how fast or slow that is determined on a number of clinical applications and problems. From 3 to 4 is what? What phase? Inspiration. Yeah, that's your inspiratory waveform. So if you had a waveform, let's go over some of these. If you had a waveform that looks like this, some people call that a shark fin. Some people call that a normal waveform. That is not a normal waveform. If you saw this, what is it, when you think about a waveform, think about what it's trying to tell you. What is it saying to you? What does this say to you?
Obstruction.
Somebody said it.
Obstruction, like asthma?
Yeah. So this would be a slowing of the emptying of the alveoli, slower than normal, right? Okay. So that could be a number of things. Could be obstruction. Could be a partial obstruction. Could be bronchospasm. Usually it's bronchospasm. Typically in asthmatics and COPD patients, you're going to see this. This is a classic waveform, like especially post-intubation. Immediately post-intubation, you're going to see this. Break out the albuterol. Yeah, because that's what's going to happen. So let's say that you have a waveform that is lower. So let's say you have this waveform and then you have this waveform. What's happening? What has changed? The amount of CO2 that's coming out. This is right here is where number 3 is where that's the end tidal number. Okay, so that's right there. So with this, graphically, you're going to have no, that's not right, because this would be like more 30 to 40. But what are you seeing here? You're seeing a decrease. Decrease in volume, decrease in the end tidal CO2. So what does that mean? You could have an airway leak. You could have hypoperfusion. You could have a number of different clinical scenarios. By the way, before I forget, I've written up here an access to capnography PowerPoint. This is you'll type in this right here. I'm sorry, that's wrong. This is right there. I just typed it in just before I came here today, and I have the PowerPoint, but it's 105 pages, and I don't want to put you to sleep. So it does have valuable information in it. A lot of it is for pre-hospital and EMS personnel, but it'll give you a lot of the physiology that we're probably going to talk about today. So let's go back to how CO2 gets into the airway. What is CO2? How would you describe CO2 physiologically? What does it represent? I'm sorry, what?
Byproducts from your cell. Waste.
Correct. A waste product, pretty much. It's like exhaust on a car, for lack of a better term. So when we measure that, if we're not producing a lot of CO2, what's happening to our cellular metabolism? It's being decreased, correct? So we think about CO2 and CO2 capnography and CO2 measurement. What is it the best measurement of? Ventilation, right? That's your single best way of measuring ventilation in humans. So where was I going with this? Metabolism. So if you have a slowed metabolism, what would cause slowed metabolism? Once again, somebody said it. There's a whole bunch of different things. Sedation, hypoperfusion states. This would be a potential for a hypoperfusion state. Shock, resuscitations. When you're successfully resuscitating somebody, when you're going from the initiation of CPR through to possibly the return of spontaneous circulation, what's going to happen to your CO2 level? How many say it's going to go up? How many say it's going to go down? How many don't know? How many don't care? No, it's going to go up. Why? Because as circulation is restored, so is cellular metabolism. So when cellular metabolism increases, what's going to happen to the excreting of CO2? It's going to be excreted through normal metabolism and out into the airways. Okay, everybody follow that? Yeah, it's really cool stuff. Years ago, when I was selling CO2 monitors, when about halfway through my career, I left the field. I quit Stanford and went out. I was working at Stanford, and decided I'm going to make $1 million selling ventilators and anesthesia equipment. Well, in 1985, which is when this happened, it just so happens that the medical economics in this country took a turn for the worst, because then the government stepped in and decided that, well, we want to monitor all of the usage of your care and your resources. So we had something called diagnosis-related groupings, and DRGs drove a lot of people crazy, and it scared a lot of people. So here I come down the road with my brand new 7200 ventilator, and I think you have a 7200 in the museum here, don't you? Have I seen it? Okay, well, I was schlepping one of those in the back of a Crown Vic wagon all over Northern California. Yeah, that was a lot of fun. So I pulled this thing into a hospital, and hey, you want to buy this neat $18,000 vet? Whoa, dodge those rocks. So it wasn't easy. So where was I going with that? I digress a lot. Sorry, but they're all pretty good stories, because you may write your own book someday. You never know.
Selling $1 million.
I was selling CO2 monitors, and nobody wanted to buy them. Nobody could afford them. So I thought, well, where would they use CO2 monitoring? I know, a veterinary clinic. So I went to UC Davis and outfitted 5 operating rooms with all this equipment. That was the biggest sale that I ever made in the year and a half that I was with Puritan Bennett. But that was almost the only sale I made. But those are still there in the operating rooms. There's anesthetic agent monitors, CO2 monitors, neuromuscular transmission monitors, brain activity monitors, in I think 4 or 5 ORs. So it can be done. I just had to get really smart and try and figure out how to beat this thing. And then I thought, no, I don't want to do this. So I quit that and decided, I know, I'll go into recruiting. Yeah, that was not the best thing to do either, because not only were people not buying medical equipment, they also weren't hiring managers, which was what I was supposed to do. I was a headhunter. So I quit that and said, I'm going to go back to what I know and do the best, and that's patient care. So I'm glad I did. 1987, went back into clinical practice and started using capnography for just about everything. So now we've come a long way since then, and we've now got some different applications. Not only do we have veterinary applications, but we have non-invasive applications. So what are some areas that you could put an end-tidal CO2 monitor on a patient non-invasively? What would you want to look for? What are we monitoring? CO2, but what is that a reflection of? Ventilation, of course. So for the patient who comes in and let's say Mr. Jones is, a fluffy guy, kind of like me, and he snores a lot, and he's got some daytime hypersomnolence, and he falls asleep a lot. What do you think his problem is? Bingo, right here, guilty. Sleep apnea. I use a CPAP machine every night. So what does CPAP do? It opens up your airways, right? But what else does it do for your physiology? And for our pulmonary function folks in the rear, they're going to tell me it increases your FRC, which it does. It has a potential to do that. Everybody understand what I'm saying when I say it increases your FRC, your functional residual capacity, the air that is left in your lungs after a semi-complete exhalation. Okay, so I can feel that when I put on my CPAP at night. Everybody seen those ads for the So Clean thing on TV? Awesome. Oh, these things I bought one. These things are awesome. They're great. You don't have to clean your equipment. You don't have to do anything. You throw it in this box, and it's got a disinfectant in it. And it smells fresh when you pull it out and put it on. It's kind of cool. So I did that. When I put it on, I can feel I can't breathe down to zero baseline. So when you look at the zero baseline, and these are inspiratory waveforms. You're going in and out and in and out and in and out. What is that space right there? What is that? It doesn't go down to zero. It's an elevated baseline, right? How come? Because you're applying something at the end of exhalation, either PEEP or CPAP. So with me, it's CPAP, and I'm not breathing down to baseline, which is equivalent to ambient air. Everybody follow that? Okay, makes sense? Good. Questions? We're done.
I have a question.
No, just kidding.
I saw a waveform like this at clinical this last weekend, and I asked the RT that was precepting me what that meant, and he didn't know, and neither did the other RTs around him. So if you see a waveform like with that kind of shape, what does that like indicate?
The flower?
Yeah, I know it was weird. And
Well, it's got, well, it could be that the patient was doing that. So you'll see that on the waveform. I would say that's a neurological waveform because that's not a normal. Did everybody, no. Correct me if I'm wrong what this looks like. Like that, kinda?
I mean, kind of, but it was very uniform. Like it was the same shape every single time.
Okay, was it waxing and waning? Going up and down and up and down and up and down and up and down and up and down?
I mean, it was just the same. Like it was just the same shape.
I'd say that'd be that'd be my guess. Without seeing the patient being there, I couldn't tell you.
Yeah, we were about to extubate him, and that was just the waveform he had, and I was like, should we be concerned? And he said, no, we extubated him. He just fine after, but I just thought it was really weird.
He could have been he could have been nervous and just doing that thing.
I didn't know if that like indicated like anything specifically or.
Not really, not that I can think of. You know, you've got your different. Yeah, that's a very strange waveform. It's an atypical, definitely an atypical waveform. I don't know. I'd have to see the patient. So you know, you can't always look at just CO2. I mean, I tell people critical care practitioners, when you go into an ICU room, back up and go to a corner. Okay, you're going to look at the total picture. It's not just a ventilator ventilating a set of lungs. You've got IVs going over here. You might have a chest tube thing going on here. You've got a Foley bag down here, and you got your ventilator and all of your monitors. So take all that into consideration before you just walk over to the ventilator, do your vent check, listen to your patient, say, "Happy birthday to me. See you. Bye." No, that's that to me. That is not a vent check. My idea of a vent check is to walk into the room, say hello to the nurse, ask the nurse what's going on with the patient since your last vent check. Are there any changes that have been made? Okay. Second thing I'm going to ask myself is, what can I do on this vent check to change this patient's outcome and get them off the ventilator sooner? What can I do? When I was at Sutter Amador, that's what I asked all of my staff to do every vent check, 24 hours a day. Our length of stay on the ventilator is 1.2 days, average. That's unheard of. Then we use the ABCDE bundle. I don't know if you've all heard of that. You've been through the ICUs. How many have not heard of the ABCDE bundle? Okay, well, it's a ventilator or an ICU liberation tool. I've been blessed with the. I created that. Some people will say, Marianne Daly will say, Tim developed this ICU liberation terminology. You'll see that through some of the literature. What we're trying to do is liberate the patient not only from the ventilator but from the ICU quickly. We want to get this patient off the ventilator because your primary objective when you put a patient on a ventilator is what? Get them off. Exactly. First vent check, 2 hours after intubation. What's your primary objective?
Lower FiO2.
Do whatever you can to get this patient off the ventilator. Two things I want at intubation, and this is getting way off the track of CO2, not really, but it kind of does. Number one, at intubation, I want a sputum culture. Why? Somebody said it. Keep your VAP numbers down, ventilator-associated pneumonia, okay? Because if you can prove that at intubation, this patient did or did not have a pulmonary infection, then you will or will not have a case of ventilator-associated pneumonia. Our VAP rates at Sutter Amador, 0 for 24 years. Yeah, because just by doing that, and it's incredible. The next thing to do is get a blood gas right at intubation. Why do you want to do that? Bingo. Establish your baseline, and what is the normal gradient between arterial and tidal? Anybody know? What's the average? Average gradient. How many millimeters of mercury?
10.
Up to 10. Yeah, 5 to 7. 5 to 7. And which is higher?
The one in the blood.
In that gradient of your AA gradient, your alveolar to your arterial CO2 gradient, which is higher? How many say alveolar? How many say arterial? How many don't know? How many don't care? No, it is arterial. You can't squeeze all of the CO2 out of capillary blood. So that's where that's excreted. Okay, so that's an important gradient for you to know as you move forward in your strategy of ventilator management. So now, do you need a blood gas? Yeah, how often? Do you need a blood gas every time you make a ventilator change?
Yes.
Yes? How many say yes? How many say no? I say no. No, I don't use blood gases. I use end tidal, unless something dramatic has happened to this patient clinically. Because otherwise it's the same. So your gradient is going to stay the same. Here's your gradient, it's moving like this, but the gradient itself is the same. Now, if something happens, patient goes into shock, or something bad happens to the patient that's going to affect that gradient, yes, then I would get another blood gas. But there are a number of places and philosophies that say, oh gee, yeah, every single time you touch a ventilator knob, you need a blood gas. That used to be, back in the 70s, we used to do it that way. And drove everybody nuts, because you try to find an anesthesiologist to put it in an art line, and sometimes you couldn't do it. But yeah, that's really, really important. So you follow your non-invasive numbers, but again, don't short yourself from the big picture. Take a look at the big picture, and you're going to know that. You walk into the room, and all of a sudden your last end tidal was 44, and now it's 51. Something happened. So that says, okay, I gotta find out what happened. So you're gonna ask the nurse, oh yeah, we gave him more medication, or the patient had a hypotensive episode, or something has happened to change that number. How else can you use end tidal CO2? When else would you use it? You can use it non-invasively, as we said. So what would be some of the indications for measuring end tidal CO2 in a non-intubated patient? Would be some regular scenarios. Yeah.
Procedural sedation.
Yes. Yeah, exactly. So that's going to be our next topic. We're actually we're heading like way fast here, because I'm running out of gas. Are there any? What is it about CO2 monitoring that's jumping out at you that you're struggling with? Anybody? Everybody got a pretty good handle on it? Yes, sir.
I didn't realize that capnography and end-tidal CO2 is the same thing, right?
Yes.
That I have plenty of those.
Yes. But there's a difference between capnography and capnometry. What's the difference? What's a metric?
Measurement.
Is a measurement. So that's what you see on an end tidal CO2 monitor. What is a capnograph? A physical representation of that. So, I mean, back in the old days, we used to do plethysmographs. Remember those? We still do that, but it's a graph. So it is a graphic representation of a clinical scenario. Does that answer your question?
It does, thank you.
Okay. Okay, good. Yeah, that's a really good question. Because yeah, it's a terminology thing, and it's a lot of times it's just semantics. You're going to find that in a lot of different areas in RT. What else is jumping out at you about end tidal? Have you been stumped on this in any of your clinicals? How many have? How many have been stumped? It's okay to say it. Yeah. What was it that made you struggle with it? You remember?
We didn't learn about it first, and then clinicals, and they were like, what is it?
Oh, you didn't learn about it. Say it again. I'm sorry.
We didn't learn about it at first, and like we first started rotations.
Uh huh.
And then when I got to rotations, they asked us like, what is this?
Oh, what? Yeah. What's capnography? I don't know. Yeah. Yeah, that can be a little unnerving. Yes,
Is
question.
the ETCO2 monitoring that they have in the nasal cannulas reliable? You know, like the extra flop in the nasal cannula?
Yeah, that's a very good question. Good point. Thank you for bringing that up. I forgot to say that. When you are doing non-invasive monitoring of end tidal CO2, what you're looking at is trending. This is a huge word you got to get used to, and that is trending. That's what we were talking about with the more frequent blood gases versus non-frequent blood gases. What are you looking at? You're looking at trending and how that moves along. Good question. Yeah, but yeah, the nasal cannula, depending on manufacturer, there are good ones and there are bad ones. There are some that have a dual lumen right at the airway, and there are some that have one that delivers oxygen and one that measures CO2. If you have a patient with a nasal obstruction, there's something to consider.
That's true.
Yeah, so those are all things to consider when you're looking at trending successfully. Yeah,
Trending
that makes sense?
Trending up or trending down in regards to
Either.
Either.
Yeah. If you got a patient that's, I'm not sure about this patient's ventilatory status. He's just had an appendectomy and he's still under general anesthesia, but he's in the recovery room, and I put an end tidal on him, and all of a sudden his CO2 starts to drop. Why?
Not breathing.
Or it starts to go up. In a post-op patient like that, why would it go up? Anybody here ever had general anesthesia? How many? Anybody ever had general anesthesia? What's the first thing that happened to you when you woke up? What did you feel?
Pain. Pain.
Pain. Okay, what else?
My breathing was different.
What did your body do? You start shivering. Okay, that's a very, very common. I would say 90% of patients that undergo general anesthesia, in the emergence of that of general anesthesia, they're shivering. What does that do to your CO2 production?
Increases.
Elimination. It goes up. So in those post-op patients, another thing that nowadays we do a lot of laparoscopic procedures. Everybody seen one?
Yes.
Okay, like a gallbladder or something like that. They use a lot of laparoscopic procedures. What do they use to inflate the belly when they're doing abdominal surgeries using laparoscopic procedures? What do they use?
Yeah. Air.
They use either nitrogen or CO2. So when that CO2 is in the belly and they don't evacuate all of it, where does that go? It dissipates to the place where it's going to be eliminated, and that's your lungs. So you're going to have an increase in your CO2 initially after, and a common mistake is to compensate for that end tidal CO2 by turning up either your rate or your volume on the ventilator when you don't need to. Or the patient could do that, but their CO2 is going to react based on what level of consciousness they have as well. So now we're starting to get into the the sedation part. Any other questions on CO2 monitoring? Okay, y'all feel pretty comfortable doing that? How many of you have not actually applied a CO2 monitor